topic of discussion is thoracic outlet syndrome. Myself, Dr. Milan Snekunj. So we will cover this topic under these following headings: introduction part, review anatomy of thoracic outlet region, potential causes of thoracic outlet syndrome, potential entrapment sites, epidemiology, typical presentation, and its management. So thoracic outlet syndrome is defined as compression of brachial plexus, subclavian vein and artery in the thoracic outlet region. It is common but a controversial diagnosis. Many conditions including angina, spinal tumors, multiple sclerosis, cervical disc pathology, carpal tunnel syndrome, tendinitis present with the similar complaints to the thoracic outlet syndrome. From history perspective, in 1821, Sir Ashley Cooper first described the symptoms of neurovascular compression in the thoracic outlet region. Then Gallen and Cooper first described the cervical rib. In 1956, first Pitt and later on in 1958, Robb and Standover introduced the term thoracic outlet compression syndrome to define all the cervical brachial pain and numbness syndrome of the upper limb. The diagnosis of thoracic outlet syndrome includes many syndromes. These syndromes are often named for the cause and location of symptoms. Some of these syndromes include costoclavicular syndrome, cervical rib syndrome, first thoracic rib syndrome, hyperabduction syndrome, brachial plexus syndrome, fracture clavicle syndrome, and humeral head syndrome. So basically the controversy arises from lack of consistent definition of pathology, lack of consistent definition of thoracic outlet region, and lack of diagnostic tests available to confirm its presence, meaning that the diagnosis is often made on the basis of only history and physical examination part only. So now we will move on to anatomy part of thoracic outlet region. So basically thoracic outlet syndrome is a misnomer. It is truly an inlet of thoracic cavity. The narrow upper end of thorax, which is continuous with the neck, is called inlet of thorax. The true thoracic outlet is bounded by T12 vertebral body, 12th ribs, and xiphisternal joint. So what are the boundaries of inlet of thorax? Anteriorly it is bounded by upper border of manubrium sterni. Posteriorly it is bounded by superior surface of body of first thoracic vertebra. On each side it is bounded by first rib and cartilage. The plane of the inlet is directed downwards and forward with the obliquity of about 45 degree. The anterior part of the inlet lies 1.5 inches below the posterior part. The transverse diameter is approximately 4 to 5 inches and anterior posterior diameter is approximately 2 inches. So what is the diaphragm of inlet of thorax? The diaphragm is divided into two halves, right and left, with a cleft in between. Each half is known as Simpson's fascia, which partly separate neck and thorax. This membrane is triangular in shape and provides rigidity to the thoracic inlet. So as far as anatomy of thoracic outlet region is concerned, three muscle plays an important part in the pathophysiology and treatment of thoracic outlet syndrome. First is scalenus anterior muscle, second is scalenus medius muscle, and third is pectoralis minor muscle. Also brachial plexus anatomy is equally important. So scalenus anterior muscle originates from the transverse process of C3 to C6 and inserts to the scalene tubercle of the first rib. Scalenus medius muscle originates from the transverse process of C2 to C7 and inserts at the cranial surface of first rib between the scalene tubercle and subclavian groove. So this is the anatomy of first rib of the left side. So we can see scalenus tubercle where the scalenus anterior muscle inserts. We can see the insertion of scalenus medius muscle. We can see the groove for the subclavian artery and subclavian vein. So pectoralis muscle originates from the third, fourth and fifth rib near the costochondral junction and it inserts at the coracoid process of scapula. Coming to brachial plexus is the network of nerves starting in the upper spine and supplying motor and sensory to the upper extremities. The roots are formed with the ventral lemma, by the ventral lemma of C5 to T1. So here is a course of brachial plexus starting from roots, trunks, division, cords and branches. So there are three cords, lateral, medial and posterior cord, and here is the root value of each nerve. So now coming to the entrapment sites, there are three main entrapment sites where the structures of the neurovascular bundle can be compressed. So cervicoaxillary canal is divided into costoclavicular space and axilla by the scalenus medius muscle. Costoclavicular space is divided into scalene triangle. Costoclavicular space is bounded medially by the costoclavicular ligament, laterally by the scalenus medius muscle, superiorly by the clavicle, and inferiorly by the first rib. It contains all three structures, subclavian artery, vein, and nerves. Scalene triangle is bounded medially by the scalenus anterior muscle, laterally by the scalenus medius muscle, and inferiorly by the first rib. It contains subclavian artery and brachial plexus. And also there is a pectoralis minor space which is bounded anteriorly by the pectoralis minor muscle and posteriorly by the chest wall. And it also contains all three neurovascular bundle. It is also called subcoracoid space. So here is a boundary of interscalene triangle, costoclavicular space, and pectoralis minor space, which is also known as subcoracoid space. So what are the causes of thoracic outlet syndrome? Majority of thoracic outlet syndrome cases result from trauma. Second most common cause has been identified as a mechanical factor. Inflammation to the fibrous band and scar tissue may also lead to compression of neurovascular bundle. Osseous factor, presence of cervical rib, which occur in approximately 0.5% of population and 5 to 9% of thoracic outlet syndrome patient. Depressed or fracture clavicle causing decrease in the space between clavicle and first rib. Prominent C7 transverse processes, congenital abnormality of first rib, malunion of clavicle, soft tissue factor, anomalous insertion of anterior and medial scalene muscle, hypertrophy of scalene muscle, tight pectoralis minor muscle secondary to faulty posture, and lastly soft tissue factors including brachial plexus anomalies and brachial plexus tumor. So what is cervical rib? It is an extra rib which arises from the 7th cervical vertebra, also known as neck ribs. It is a congenital abnormality located above the normal first rib. Cervical rib is present in less than 1% of population, bilateral in 50% and common on right side. It is usually asymptomatic. So there are 4 types of cervical rib: completely bony, completely fibrous, combined, and bony swelling. The type 3 is most common, which is partly bony and partly fibrous. So here is a figure showing a cervical rib which compresses subclavian artery in the scalene triangle, and we can also observe post-stenotic dilatation. In figure A we can see bilateral cervical rib. In figure B we can see post-stenotic dilatation due to cervical rib. Now coming to epidemiology part, incidence is 1 to 2%, usually occurs in 20 to 50 years of age. Male to female ratio is 1:3. There is no racial predilection, and most common type is neurogenic TOS, which accounts for more than 95% of thoracic outlet syndrome. Second most common is venous TOS, and third is arterial TOS. Classification, depending on exact site of injury and injury component of the neurovascular bundle, it is classified into 3 types: neurological syndrome, venous syndrome, and arterial syndrome. Most common is neurological syndrome. It is also classified in uncomplicated form and complicated form. The complicated form is true TOS. So what are the symptoms of brachial plexus irritation? Tingling, numbness, usually in C8 to T1 distribution, coldness, paresis, early fatigue, progressive weakness, and discoordination of upper limb. This is a dermatome of upper extremity. What are the symptoms of arterial involvement? Pallor, coldness, fatigue, muscle cramps, pain secondary to ischemia, diminished pulse, gangrene, Raynaud's phenomena. Symptoms of venous involvement: swelling, heaviness, fatigue, cyanosis, Paget-Creuetter syndrome, which is effort axillary subclavian vein thrombosis. Now coming to diagnosis part, the most accurate diagnosis of thoracic outlet syndrome must rely on the careful history and thorough physical examination, which was said by David Roos. There are various clinical tests which are helping to make a diagnosis of thoracic outlet syndrome. First is Edson test. Patient is requested to take a deep breath and rotate and extend their head as far as possible towards the affected side. The examiner fingers should be placed on the radial pulse. This test will reproduce symptoms and obliterate ipsilateral radial pulse because it decreases space between scalenus anterior muscle and medius muscle. It is known as scalene test. One can also listen for the bruit underneath the clavicle to document compression. Halstead costoclavicular test. Patient is requested to sit straight in the exaggerated military position and radial pulse is assessed. The positive test is called when there is change in the radial pulse or there is pain or paresthesia. Hyperabduction test. Patient externally rotates the shoulder and arm is hyperabducted to 180 degree, which diminishes the radial pulse. It evaluates the compression of neurovascular bundle between the coracoid process and pectoralis minor muscle. Roos test. Patient is requested to hold the both arms in the surrendering position, and positive test is called when there is pain or paresthesia or discontinuation of the test with a drooping of the arms for relief of pains. Modified Roos test is called when symptoms precipitated by opening and closing fist continuously. So these are the differential diagnosis of thoracic outlet syndrome, which includes cervical spine pathology, tumors, peripheral nerve pathology, vascular phenomena, and other diseases like angina and esophageal spasm. Plethysmography as an aid for diagnosis. Pneumoplethysmograph is an instrument which evaluates small amounts of air pressure changes. The arterial waveform that this machine records is commonly called as pulse volume recording. Now coming to investigation part, chest X-ray, cervical spine X-ray, Doppler study, MRI, CT scan to rule out any space occupying lesion, decompression, narrowing of intervertebral foramen, vascular imaging, angiogram, venogram to rule out aneurysm, thrombosis, nerve conduction study, electromyography to localize the area of compression, X-ray cervical spine for cervical ribs, elongated C7 transverse process, degenerative spine disease, bone destruction. Duplex ultrasound, it is highly sensitive and specific test for venous stenosis or occlusion. It may demonstrate increased flow velocity in the stenotic area in arterial trough. Arteriography and venography. Conventional arteriography and venography may demonstrate the presence of external compression, but it do not allow the clear depiction of impinging anatomic structure, and it is replaced by less invasive procedure like CT and MR. CT angio, MR angio, traditional angiography can be utilized to identify more clearly occlusion, aneurysm, thrombosis, distal embolization, and to plan surgical reconstruction. So here is a MR angiogram showing subclavian artery stenosis in young lady. Here is the MRI showing anterior muscle asymmetry in scalenus anticus syndrome. Now conduction study. The conduction velocity is determined with the Kruse and Caldwell technique. The ulnar nerve is stimulated at the 4 points with a spatial stimulation unit which imparts electrical stimulus of 350 volt, and the duration of stimulus is 0.2 millisecond. So velocity is calculated by distance between adjacent stimulation point divided by difference in latency between adjacent stimulation point. So accordingly, grading of compression is given in slight, mild, moderate and severe. Any value less than 70 milli per second indicates neurovascular compression. Now coming to treatment part, no treatment can be successful unless a proper diagnosis is made. The diagnosis of cervical spondylosis should be ruled out, as thoracic outlet syndrome is at times associated with the cervical spondylosis. The realization by the patient of a proper posture is of paramount importance to the treatment of thoracic outlet syndrome. Conservative treatment includes physiotherapy, posture improving exercises, breathing exercises, and analgesics and muscle relaxant. Surgical treatment is the last option. Now coming to surgical treatment. Indication for surgical treatment: whenever the conservative treatment fails, symptoms leading to job loss or affecting quality of life, muscle wasting, and progressive loss of function, and arterial complication. So surgical treatment includes first rib and cervical rib resection and scalonectomy or combination. First rib and cervical rib resection, there are various approaches. Transaxillary approach, which is also known as Roos technique; supraclavicular approach, which is most commonly pursued; infraclavicular approach, and posterior approach. First rib resection, transaxillary approach. It is performed under general anesthesia. Patient is in side-lying position with a chest at 45-degree angle. 6 cm spinal incision is kept at the level of third rib. Costochoroid ligament cut from the first rib. Anterior middle scalene muscle cut near its incision. First rib is removed, and during this procedure, cervical rib is, if cervical rib is present, they are also removed. So here is a incision site which is at the level of third rib. Resection of first rib is recommended mostly in patient with lower brachial plexus involvement, nerve roots involving C8 to T1. This procedure is often performed before in conjunction with the scalonectomy. So what are the possible complications with the first rib resection? Brachial plexus damage, intercostal brachial nerve injury, bleeding, and pneumothorax. Scalonectomy, it is performed under general anesthesia. Chest and head is elevated to 30 to 40 degree. Neck is hyperextended. Incision made from the medial border of sternocleidomastoid to anterior edge of trapezius muscle. Scalene muscle divided and removed from the C5 to C8 level. Approximately 80 to 90% of anterior scalene muscle and 40 to 50% of medial scalene muscle are removed. This procedure is often used in the patient with upper brachial plexus compression, root involving C5 to C7, and excessively muscular or obese patient. Scalonectomy is often performed after or in combination with the first rib resection. So what are the possible complications of scalonectomy? Neck hematoma, long-lasting dyspnea due to phrenic nerve irritation, additional complication of first rib resection if combined with scalonectomy. What is the treatment of arterial DOS? Surgery must be performed on the emergency or semi-emergency basis. Thoracic outlet decompression, proximal arterial reconstruction, and management of distal embolic phenomena. Benefits and drawbacks of surgical management. Benefits: effective in relieving symptoms in severe cases of TOS, and drawbacks is there are very high incidence of complication. To summarize, thoracic outlet syndrome is a common diagnosis, but it is often a controversial one, often made on the basis of only history and physical examination. The syndrome occurs when neurovascular bundle is compressed. This entrapment usually occurs at the interscalene triangle, costoclavicular passage, and pectoral minor space. Thoracic outlet syndrome is basically result of traumatic mechanical or inflammatory processes and involve osseous and soft tissue component. Conservative treatment is generally attempted first, and it consists of mainly physiotherapy, postural exercises, breathing exercises. Surgical treatment generally consists of first rib, cervical rib resection, and scalonectomy. Thank you.